Welcome to the Women's Health Podcast. I'm Anthony Lowe, the Physio Detective.
And I'm Monika Hart, a pelvic health and musculoskeletal physio. Together we interview leading authorities, we answer questions and share our thoughts to provide the general public with the best quality information that we can find on all aspects of women's health. Please remember that the materials and the content on this podcast are intended as general information only and are for entertainment purposes.
They're not intended to be a substitute for professional medical advice, diagnosis, or treatment. Now, sit back, grab your favourite beverage, or do your own thing, and enjoy the show. Welcome back, everybody, to the podcast. Welcome back. I'm Anthony, your host, and Monika, my awesome co-host. How are you going, Monika?
Pretty good, thanks, Anthony. I'm very happy that it's starting to get sunny and warm here in Perth.
Yes, it's getting sunny and warm here in Sydney too, and I'm no doubt it's getting cooler with our new guest, Monika, on this podcast today. Monika, I'm just going to read out your bio here. Monika, originally Austrian, has been working as a physiotherapist since 1989. After experiences in medical center, clinic for psychosomatic, regional hospital, and private practice, she's entered the field of education in 2006. She worked as a lecturer for physiotherapy in the Bachelor and the Master's program for 19 years and has been a member of the research team for 10 years. She holds one MAS in health and fitness and one MSc in sports physiotherapy. Finally, her experience as a pelvic floor physiotherapist and her training in sports science led her to the research area of stress urinary incontinence in physically active women. In 2017, she received her PhD in that topic at the University of Bern. She left University of Bern recently and is setting up her career as a freelancer, still with a lot of enthusiasm in teaching and educating and a little clinical work. She's written a book about body competence that will be published now in November. It is in German. Welcome to the podcast, Monika. Thank you for being here.
Thank you very much for having me.
I met Monika recently doing the pelvic health, the female athlete course in Zurich, in an outlying area near Zurich, and I just reached out randomly to Monika, thinking, if I get lucky and she sees this, who knows? And you saw it. You joined us on the course the whole weekend. It's fantastic to have you there. And yeah, it was a fun weekend and lots of talking. And I thought, I have to get you on the podcast and share all the wisdom that you have to everybody who listens. So I'm looking forward very much to hearing on all the different things we're going to talk about today. Can you start by telling us how you got started with, physiotherapy, pelvic health, and active women, and the education as well as the clinical side? Big question. Go nuts.
Yeah, sure. I'd love to. So when I was in the physiotherapy training in Graz, which is my hometown in Austria, I had one lecturer who always shared her experience, her work experience about Switzerland. And I was very curious. I wanted to go beyond the normal fence of the border of the own country. And I was very interested. So as a very young physiotherapist, I got into Switzerland. And my second employment was a clinic for psychosomatics. And this time I realized right now was very much influencing me because I was very young and I experienced things that really blew my mind, also very touching and emotional things. And I was there saying one sentence to myself. I said to myself, I want to become a physiotherapy who is not only working with the soma, with the body. So I realize now that being so young, somehow that sentence really influenced my whole career later on, because from that point on, I started to be very interested also in psychology, in psychotherapy, in other fields of human being. And then I followed to become a physiotherapist in a regional hospital, and I had some small teaching opportunities at that time. I was still young and I realized, wow, that feels very good. And people gave me a feedback that I teach in a very understandable, clear way. The topic can be understood very well, and that I can really fascinate with the topic. So I have been thinking about that, and well, I proceeded my career. I became a workplace health physiotherapist. I have been working with several now my English words, several companies in Switzerland. And then this job opportunity at the University of Applied Science in Bern came up, and I applied for it 2006, and I got the job. And so I have been there now for nearly 20 years, and I loved teaching. So I came back to the basic training. My main teaching was in the bachelor program, and then finally I started also to teach pelvic floor for physically active women in the master program. Yeah, these were my basic employments, and so you can see that now that I have published the book. It came out last week in the German book market. Unfortunately, it's not translated yet, but let's speak about that later. I realized that the beginning of my career with this clinic for psychosomatics was really very helpful for me. It opened up my mind. And I'm so thankful for that I was triggered by that opportunity, and that I really learned to apply a more holistic and integral perspective for my work.
Monica, can I just ask, because I don't think we have that term, sort of the psychosomatics. I mean, like, I think a lot of people think about something being psychosomatic. There's a certain connotation that comes with that. And when you're talking about a clinic of psychosomatics, what does that look like? Like, is this a multidisciplinary clinic? Is this for certain conditions? Because I don't think we have an equivalent in Australia, maybe.
Oh, that's interesting. Yeah, we have a lot of clinic for psychosomatics here in Switzerland, and I think also in Europe. It's a term that is used in Europe too. So a clinic for psychosomatics, yeah, it is a multi-professional, of course, has to be. And there were 2 floors, 2 levels of the building. And the first level was an open ward. Can I say ward? Yeah, open ward for psychosomatic diagnosed patients. And the second level was a closed ward for psychiatric patients. So it was closed because of the danger of doing suicide and so on. So also psychosis and borderline problems and so on. And so we had a physiotherapy team of about 4 people. We had very nice therapy training room. We had a bath, so I could do underwater therapy also. And I hope that this helps you, Marika, in your understanding.
Yes, I can see that when you're talking about the locked ward, so that's for the patients who are saying are a safety risk to themselves and potentially others. The other patients who were in the other floor, what sort of conditions were they coming in with, or how were they presenting?
They would have chronic back pain, where the doctors suspected that the dominant aspect of the pain would be psychosomatically influenced, as an example. And as an example for the second floor, unfortunately, one of my patients could open something, although everything was closed, doors and windows. So this young lady unfortunately could open a window and she tried to commit suicide, but it was not successful because of the second floor. Going down to a grass field was not enough. So she had a sevenfold pelvic fracture. And this was one of my tasks, to do the rehab afterwards. Yeah. So I think that this gives you a little bit of information which patients I was treating at that time.
Yeah, it's really interesting. It's a very interesting approach. So it sounds like you've kind of had a broad background, and like Anthony and myself, musculoskeletal sports, and then into what brought you into pelvic health? Like, what, I guess, made you interested in stress incontinence and athletes? Where did that desire come from?
Good question, Marika. I was working in this regional hospital, and I was also working at the, how do you call that? The delivery ward? What is the English name for that? The delivery ward, yeah. And so
We call it maternity or obstetrics.
Maternity ward,
Yep.
maternity ward. And I think that was the time when I started to become interested into the pelvic floor. At that time, the trainings in Switzerland have just started, and I attended a course, and I liked it. I thought this is interesting, and then I worked as a pelvic health physiotherapist. I did pelvic health rehabilitation also in my private clinic that I had at that time. And it was only when I got to the University of Applied Science where I could enter the research field at all to get closer into the topic. So I had a practical background before I got to the University of Applied Science, where I got in touch with science, with research.
That's it's great that you had such a strong clinical background and diverse experience before commencing, your research journey, rather than finishing your degree and then going straight into research. It's fascinating because, I don't know how old you are, Monika, but I'm old enough to have seen many different trends come and go in pelvic health. And, we got to talking when I was in Switzerland about the automatic pelvic floor thing. And, you've seen a lot of the course has automatic type tendencies, right? Like trying to train it automatically. Can you tell us more about what your PhD found about those things?
Yeah. And I have no problems to tell my age, Anthony. I'm 57, and I can say that quite easily because I feel really fit, and I am fit. So actually, I was 49 when I received my PhD. So I think that this is really late in my perception. And so, yeah, I have to tell you something else. So in Europe, we have a completely different training system for physiotherapy, as you might know. In Australia, it has always been on a university level. So this hasn't been that way in Europe. So only in 2006, Austria and Switzerland decided to take physiotherapy from a normal training to the academic level. Only 2006. And so you have to understand that we physiotherapists, we had a lack of certain topics that you will have been taught at university. For example, methodology, research, statistics, and so on. And so I was so lucky that I could become member of our research team, because there was the person who was in charge and who was later my mentor for my PhD, Dr. Lorenz Radlinger. He was a sports scientist, and he really he put a lot of effort in getting physiotherapy on this academic level and helped and supported a lot of physiotherapists to get the lacking knowledge in order to do it, to just do it, to do research work, and to do a PhD, for example. So in this way, I try to give tribute to my mentor, and I'm very thankful for that. And I have been doing 2 master degrees at the University of Salzburg at the Institute of Sports and Movement Science. And so with these 2 master degrees, I was connected to exercise science very much. And he realized that I had a clinical background being a pelvic health physiotherapist. And so he approached me and said, Monika, why wouldn't you like to put those 2 things together? You have a lot of knowledge now from movement and exercise science, and you are clinically experienced in pelvic health rehabilitation. So why not put those 2 things together? And I was thinking about it, and I thought, that sounds great. And it sounded like a little bit sexy because it was a topic that not many people are doing, you know. In that way, I wanted to express it was attractive for me. It was an attractive topic. And then we realized what we do not understand about the pelvic floor. And I'm a hobby runner, and only for leisure time, never a competitive runner. And so we came up with a topic. We do not know a lot about the pelvic floor contractions during running and what happens during running. And we were thinking a lot about eccentric and concentric definitions. And then he said, Monika, when you start, it would be best if you would first do a systematic review about pelvic floor displacement. And then I worked a year or a little bit more than a year on this review. I scanned and screened and included 80 full, how do you say, full papers, 80 papers, full text papers. And it was such a good idea because then with this review, the questions came up, many questions came up. And we realized that some authors in the scientific literature write about eccentric contraction, but actually we do not know what it is. Can you prove it? And how do you prove it with the pelvic floor? There are many assumptions about eccentric load, but yeah, who knows more about it? And then we got into the topic and we decided that I would like to prove if there is a stretch shortening cycle while running in 50 women who were treadmill running in our lab.
It was exciting to see the results. Can you tell us what you found? Because, you know, especially at that higher speed, what the pelvic floor muscles were doing. And I think you compared it to voluntary contraction, right?
Yes, yeah. So let me first share a little bit about the instrumentation. And it's interesting. It is only a few years back, but I really have to recall, how did we do that? Because I'm not in research anymore. I think.
Yeah, I was really curious what devices that you used, etc.
Yes. Yeah, so we used a vaginal probe for the EMG measurements, the electromyographic activity of the muscles. And then we used TrackStar. And TrackStar is a little tiny sensor. It's half of the little finger snail, very, very tiny. And this is a motion tracking system. So we realized in order to prove whether there is a stretch shortening cycle, and I define it for the audience. A stretch shortening cycle is a compound of having first an eccentric contraction of a muscle followed very quickly by a concentric muscle action. And so we realized we have to prove it, first of all, with electrical activity, because the literature told us that in an eccentric load, the EMG activity is lower than in a concentric one. So we were expecting to have lower activity while there is an eccentric contraction. And the second instrumentation, the TrackStar, helped us to monitor the displacement of the pelvic floor. So we could match downward and upward and many more movements, but we only statistically analyzed the two movements, downward and upward.
Sorry, Monika, where does the TrackStar go?
Okay, so we used the Stimpon probe, which you might perhaps know. It's also sometimes only as a probe used as a sports tampon. And we had a plastic part of this probe where we put a little pipe, a small pipe that was 1 centimeter long. And we glued it, we glued this pipe, and on the side wall of this pipe, we could attach the TrackStar sensor.
So the TrackStar sensor was attached to the probe, which is measuring EMG.
Attached to the probe, exactly. Yeah. And the TrackStar sensor was slightly outside of the vagina, And I have really to admit that all my research wouldn't have been possible without the team. It was not only me. And in our team was a biomedical engineer who really calculated that in a very subtle way that helped a lot and supported when I had a lack of knowledge how to calculate it. But basically, we could match the displacement of the pelvic floor with the electrical activity of the pelvic floor. And that was the way how we tried to prove whether there is a stretch shortening cycle. And we had a hypothesis, and the hypothesis was that when the heel strike would take place, that this would be the moment when the pelvic floor would move downwards caudally, when there would be a displacement caudally, which hasn't been the place. It was not proved. Yeah. And so all our 50 women, our study population, were asked to do heel strike running, even if their natural style of running would have been forefoot. But there were only, I think, 2 or 3 women whose natural foot strike would have been forefoot. So those have been asked to use heel strike because we had sensors in the treadmill to take up the pressure in order to very exactly on the millisecond time the recording so that everything would work fine. Yeah.
So these were participants who were continent or incontinent? Was this a baseline, like a control?
They were continent and incontinent, half-half, approximately half-half. Okay. And we used the I6 score, and this is a 20-degree score. And the incontinent patients had score number 6. So they had a mild incontinence. Yeah. You know,
and across the board, you did not see that stretch shortening cycle happen.
We saw a stretch shortening cycle. Well, you know, it is interpretation if it is a stretch shortening cycle. We saw a downward displacement that can be interpreted as an eccentric load. And we saw an upward movement. But our hypothesis has not really been proven because 2 aspects. First of all, the downward displacement started 100 milliseconds before heel strike. We were very surprised about that data. We went back and forth and discussed and calculated again. And this was it. This was our result. So 100 milliseconds before heel strike, the pelvic floor started to get down. So when the heel strike took place, it was the lowest point of displacement, which was followed by an upward displacement soon afterwards. So this was surprising because we didn't at that time understand why is it 100 milliseconds before heel strike. And the second thing about the correct definition of stretch shortening cycle, we saw that there is not a lower EMG activation. Instead, we saw a high pre-activity of the pelvic floor in those 100 milliseconds before heel strike. So I interpreted it displacement, yes. Stretch shortening cycle, I'm not sure. Perhaps we have to think differently with the pelvic floor. You know, we know it is anatomically, it is a skeletal muscle, but should we cope with that the same way as for the quadriceps and for the biceps? Perhaps we have to think in a different way for the pelvic floor. And it was not a lower EMG activation. So the second aspect I interpreted as the pelvic floor is just so intelligent and our body is just so intelligent that knowing you are still in the air and the pelvic floor knows that there will be a touchdown and more activity is taking place. So I don't know how what are you thinking when you listen to these results? What is your thought? What's going to your brain?
I literally wrote to Marika. I said, I wonder.
I was like, I know Anthony wants to just dive in here.
I wonder if the pre-activation of, say, transversus generates a small increase in intra-abdominal pressure, which causes maybe just a little bit of descent. I don't know how much descent you saw. And then the reactive contraction of the pelvic floor timed with, do you know what I mean? Like it's a coordination motor pattern. That's just off the cuff.
What I like with this idea, Anthony, and I don't know whether it was touched on your female athlete course that you have given just recently in Switzerland. I love the aspect of the intra-abdominal pressure. So far, many of us view the IAP as being the enemy. It's doing harm to our pelvic floor. And in my understanding so far, I think, besides the fact that it is wonderful for clearing our airways and many other positive aspects, for the pelvic floor, I think it could be a very helpful trigger. So if IAP is only creasing a little bit, perhaps this is like a messenger telling the pelvic floor, get ready, get ready, get ready. And so it is a helpful instrument, not a bad instrument that is harming the body. So I think we are on the same line in that thought. What do you think?
Yeah. Like Paul Marika has heard me bang on this for years. I see so many pelvic health physios who use an increase in intra-abdominal pressure via abdominal contraction, because I have my hand on the abdomen and I can feel abdominal contraction before pelvic floor muscle squeeze. I think a lot of people use pressure to generate that pelvic floor muscle activity. Very few people truly isolate in the traditional way of, like, I see so much pre-contraction from other places, and it's like they use that to get feedback because they don't have anything down there to feel. Anyway,
the only other thing I was thinking about is just, we're talking about gravity, right? And we're talking about organs. And as you're coming down to land and you're getting these organs coming down as well, I wonder whether the weight is causing that little bit of stimulus would be the other thing.
It's still
Think so,
IAP.
I mean, before that time frame of 100 milliseconds before heel strike, we have another time frame where probably there is a short period of time with no weight because of the deceleration. And I think the 100 milliseconds before heel strike could be the time period where the whole content of the abdominal content with gravity would start to get down, increasing IIP a little bit. Yeah.
Mm.
So what I found really interesting, we in our research team were discussing it forth and back, and we published it. And you know that I was in touch with the research team in Salt Lake City with Professor Bob Hitchcock and his team, and I think it was only 3 years ago when Stefan Niederauer, I can send you the reference if you want to. Stefan Niederauer did nearly the same study. It was running with females, and they measured, I think, EMG and IAP. I'm not 100% sure whether I'm giving this, whether I'm sharing this correctly, because I have been reading this study, I think 3 years ago when it was published. And they had a completely different approach to analyze it, also statistically. They did a wavelet analysis of the EMG measurement. Wavelet is, you know, wavelet? So it's a very complicated method. And Stefan Niederauer is a genius in that. And they came up with the same conclusion. I couldn't believe it. There was a graph, there was a figure in the publication, and I was going, wow! So they were replicating it in a way using different methodology. Yeah, that could be that this is the reference, yeah. And they came up with the same result. So I had a good feeling afterwards, because I was thinking we didn't really understand our results to full extent. But anyway, it seems that it has been replicated and the results are quite similar. So I think there is time to rethink some old assumption, throw it away, think in a new way, think around the corner, and so on.
And Monika, I'm sorry, I was just looking at another study that you did, another one looking at jumping as well.
This was my colleague. Yeah, I was analyzing the running results, and my colleague, who also did a PhD, was analyzing the jumping results. And basically, in both of those reactive actions, we could see that, and we could prove actually that there is a reflexive contraction of the pelvic floor taking place in running about 130, 150 milliseconds after heel strike. There is the highest peak of EMG activity. And with jumps, and my colleague Helen Moser was analyzing the counter movement jump and the drop jump. And she could also see the peak of muscle activity after, I think, 150 milliseconds, which was much, much higher than the maximum voluntary contraction.
Sorry, was that during the takeoff or was that the landing? Sorry, I missed that.
It was the landing. Actually, she calculated both. So with drop jump, she calculated the first landing, then speed up to the air again, and the second land, first and second landing. And with counter movement, jump the same. Yeah. So Helene Moser.
So what's counter movement? I don't think I know that term.
It is the jump. You are in a slightly squatted position. You have your hands on your pelvis, and you take a deeper knee squat in order to explosively jump up to the air and land again on your both feet.
Oh, so it's a vertical. Okay,
Counter
gotcha.
movement jump. Exactly.
Yep.
Yeah.
Yep. Okay. And following on this research that you've done, and obviously the mob in Salt Lake City have done as well, where's that led to? Like, where are we kind of?
Okay.
So this was 2000 and what year do you reckon?
These publications were published 2018, 2019, about that. Yeah, that's time. And so the implication was that we saw, okay, it is not enough to do voluntary contractions. This is the basic message. It's not enough. It's not bad. And I still use a lot of voluntary contractions in my pelvic floor rehab. And I think this is fine. And it would be my first approach in order to raise awareness of the muscle contraction at all. I mean, many women have no clue how to do it. But it is not enough, because all the stress urinary incontinence triggering aspects take place within 150 milliseconds. So a cough, peak flow 150 milliseconds, sneeze, taking a handkerchief and blowing into the handkerchief. You know, this takes place in 150 milliseconds. And in my study population, I measured the fastest voluntary contractions that my 50 women who took part in the study could do. And it was a little bit more than 417 milliseconds. So we need half a second for the voluntary contractions. So with that result, we realized it's not enough to do voluntary contractions. We only train part of what the pelvic floor has to be ready in everyday life and in a day of a physically active woman. And so one implication was a randomized control study that one of my colleagues of the research team, Dr. Helena Luginbühl, was doing. She did a randomized control study with her research team. She was in charge of the study. And there were 96 women taking part. They were separated into groups. One group, they were stress urinary incontinent patients. And one group did the conventional physiotherapy pelvic floor program that is being done in Switzerland. And the second group did something plus. And the plus were small impact activities. Impact activities like first some subtle jogging steps on the spot, then a week later, taking your knee a little bit higher, doing 10 running movements on the spots, then jumping from a stair or jumping onto a stair. So we included impact that I can only share it from my training background. For 25 years, physiotherapists tried at all cases to not have a woman leak while she is with you training in your clinic. You would try to avoid everything that would be embarrassing. And now we realized, no, we have to think in a different way. Perhaps we have to inform the patient very well that incontinence could be a sign of fatigue. And with muscle hypertrophy, we know one aspect that is the same through all the different methodologies of doing hypertrophy training is get the muscle to be tired, get it to be completely fatigued, that you can't do one rep more. So how does this translate into the pelvic floor? And we came up with the idea, well, if we really try to consistently translate that into the pelvic floor, that would mean that we have to be training until the leaking takes place. And this was a completely paradigm shift. We tried to avoid it for centuries, not to have this thing happen during the therapy. And so we had this approach in mind that we inform the patient you could leak, and it is a good sign that you leak, because then the pelvic floor shows the pelvic floor is fatigued. He can't do anymore. So that is a reason why you leak. Try to protect yourself with a sports tampon, for example, and then do the impacts. And so half of this population was doing slight impacts, but I have to admit at that point already, we haven't been very courageous. we put impacts into the protocol, and the result of the study was that there was no difference between the groups. So we have been very disappointed, because we have been so convinced about our approach that we need to use impacts for the pelvic floor rehabilitation as an important second aspect besides the voluntary stuff. And then we discussed about why didn't we get another result?
Sorry, and Monika, your results that you're looking at, I'm assuming, were your stress incontinence symptoms, yeah?
We were hypothesizing that the group with the impact training would become better in the retest of the EMG activity and so on. But there was no difference, no statistically significant difference between the groups.
What about in terms of their symptoms?
This is a good point, and it was published in that way. The group that did the little impacts have not worsened, which is a very nice finding, I think. You know, when you start, you have to be humble anyway when you do research work. And even if you are disappointed that the difference wasn't there, statistically significant, we were at least happy to have the result that the impact group didn't worsen. I mean, that is already a nice step forward to the research community. And looking back retrospectively, we think that basically, statistically, if we could put up the number on 200 participants, it might be that there would have been a statistically significant difference. You are aware about that fact. And the other point was that we thought we were not courageous enough with the impacts. So far, I left university. I don't know about the plans. I think it is not planned to do a second one, but perhaps other groups worldwide in the research community could replicate that study. And the protocol has been published, and you can see on how much degree of impact the second group was doing. But the second time, we would be much more courageous with impacts. Does that make sense to you?
Yeah. I wonder, I think you are very courageous to encourage them to go to leaking. Like, I'm more conservative in that way, in that I get them to stop just before the leaking. They go, oh, if I do more, I'm going to start leaking. Or you saw on the course, they do a tiny amount of leaking and then we go a little bit less. I wonder if slightly lower load, because skeletal muscle research shows that you don't have to go to failure to get the strength benefits. So slightly lower load, more sets, like more training volume, and able to function, without leaking for the rest of the day, for example, because they're fatigued. There's many variables there. My mind is exploding at the moment.
Anthony, with your approach, may I ask you, with your approach, doing lower load and higher volume, do you follow rather to the hypertrophy aspect of the muscle?
No,
Which
because
aspect?
hypertrophy to me is not as important as strength. And
Exactly.
I know that hypertrophy, cross-sectional area relates to strength, but but cross-sectional area doesn't always guarantee the end result strength, right? So
I completely agree. Yeah, I completely agree. And this was our thought in our research group. We realized one of the decisive aspects is rate of force development. It's all about that. I mean, to bring up that curve in the steepest opportunity in order to make the pelvic floor ready for these very quick reflexive challenges that are occurring during daily life and during high performance activity, we need to get the curve to make it steeper. And this is why we call that training, that type of training, I would call in a exercise science perspective, reactive training. It is reactive force. It is a reactive force, and it is a I'm lacking of a word now. Ausdauer. Tell me what is running? Running is improving
Cardiovascular. But you're talking about like an automatic,
reflexive, unpredictable, predictable.
No. What is the opposite of I will look it up later. I don't have my
That's okay.
If when you can do something very long, you call it
endurance.
Endurance. Thank you. My brain was just not
you
working.
Speak more than one language, Monika. You're doing great.
Thank you so much.
You're so ahead of us.
So what we think, and I'm still completely convinced about that perspective. What the pelvic floor needs is not only the reactive force, meaning rate of force development in the steepest way to get the curve steeper, but also reactive force endurance.
Yes.
And from a clinical perspective, I tried to put this into practice, what I have been researching or my research thoughts. And there was a woman coming into my clinic. She was a CrossFit athlete. And in taking the history, I realized her main problem is single unders. And when I asked her, when does she start to leak? She said she starts approximately with number 9, single unders. And this is not so much challenge compared to double unders. And so I tried to put into practice this approach. And I told her that leakage could be a sign that the pelvic floor is fatigued and that she should use a sports tampon and try to stay active. She was training, I think, 5 times a week in the CrossFit box. And she understood that very well. I think this lady was about 40 years old. And she continued with single unders. And I also did the voluntary work. I did the awareness training so that she became more aware. And I think after 4 weeks, she was at 14 single unders. And when I stopped the therapy with her, she was with about 20 single unders before the leakage took place. So concerning the hierarchy of evidence, this is at the lowest part. It's an expert opinion, but I changed my mind about the evidence-based medicine in the last years. And I think the randomized control study is not just, it is the gold standard and the other parts and systematic review and meta-analysis even more, but I think we miss something, and I would like to emphasize more that this pyramid has a base, and the base is the expert opinion and the single case study, and this is not bad. I think we were a little bit over exaggerating the RCT. Do you agree? I see your head going. I'm happy for that because in
I
the
think we
kind,
just acknowledge that people are just that we don't have a homogenous
yeah,
population,
and we
and
miss
for
and
applying
we
a generic thing across the board, we're never going to see a fantastic well, we're rarely going to see fantastic results in physiotherapy by applying one thing across the board to a
and I think if we
heterogeneous population.
yeah, and I think if we do not acknowledge that there is this basis of the evidence hierarchy, having the expert opinion and single case study, we miss out of some interesting new ideas or questions or thoughts. I'm happy that you agree with that because sometimes I felt a little bit alone with this perspective that I personally have.
um, how much do you think, Monica, the improvement was related to the sports tampon versus the muscle training? I'm just thinking from like a fascial urethral
Ah,
hypermobility kind of perspective,
okay.
how much
So,
that support might help.
very good point, Marika. I think I didn't share that exactly enough. The retest was when she did not use the tampon. So the retest with at the end of the therapy, she was about 20 single unders without tampon, was without, yeah. But the training, during the training, she used the tampon, yeah. And actually, Marika, I have no idea about the impact of the tampon. Um, I don't know if the tampon is only protecting or whether the tampon does do something else to the muscles. Would it trigger activity? I have no idea. What do you think?
Well, I'm just thinking because we often use it or contiforms or ephemeras or those continence devices just to provide that backstop against the posterior urethra to stop that funneling happening. So I was just wondering, but that's interesting that even without it, that she was
Yeah.
able to go a lot more. But maybe by putting that in while she was training, she was leaking less, so she was able to do more. So therefore, she was building up that capacity, maybe. Um,
Exactly. Yeah.
as a side note, I was just curious when you did the research with these, or your team did the impact training research and then reevaluated the EMG and movement and everything else. How long was that training period for? Are we talking like 12 weeks or?
I think it was 12 weeks. It was 3 months. Yeah. I would have to go back to the paper to be very
Mm,
exact, but I have the gut feeling it was 3 months. Yeah.
yeah. Okay. I'm going to be quiet now because I'll let
And
Anthony.
this is also an interesting aspect that it could be changed in the replication of the study, for example, to do another time frame, to do it for 6 months, for example, to have it longer. Yeah.
Yeah, it's I agree with you. You know, the thing that always interests me about studies and RCTs, and they've talked about it for decades, is subgrouping and who might this be good for. And you see such a wide variety of results. You see some people that absolutely cured, though rare, it's absolutely cured. And then a lot of people, significant improvement. And then you got some people not responding at all. And you got some people worse, right? But overall, if it seems to improve, well, then we say it improves. But then people say the research shows that this improves for whatever condition you have. But then they don't tell the person, look, there are some people that get worse and some that don't get better at all, and some that have a small improvement and some significantly good, because we just say it all improves. And, I think with respect to where we're going, and communicating and educating for the audience, where do you think, the research should be so that we can take into account all the case studies and all the information from the clinicians and all the, well, we tried this program with this small group of people, we didn't take notes. I can tell you that I don't have a program for a diagnosis. I have different people doing what they need or what I think and they think they need to do. Do you know what I mean? So it's very hard to apply a single protocol to somebody, because I could be sitting there going, this is not right for you. This is like, you don't need this, you need this. Do you know what I mean? Where do you think we should go? You know, using your clinical and your research experience, where would you like to see physiotherapy go in this area? Because this automatic activation thing, and training for that automaticity, like I've been trying to do this for a long time, and it's very difficult to get big chunks of populations to change
Yeah.
without the
So
research.
This is a very good question. Where to go in the pelvic floor rehabilitation? First of all, I would encourage patients not to withdraw from physical activity. Physical activity is just so beneficial for the overall health. We don't need to discuss any longer about that fact. Secondly, I think we physios should be a little bit more courageous to try out things. And as you mentioned, research is controversial. We have no completely one track. Research is telling ... It is very diverse. And in that way, we should also treat our patients diverse, individually. And your slogan on the course, make things differently. Always try out things. Try to change your stimuli. And then I would love if we could get rid of one perspective. That is the perspective, there are the good exercises and the bad exercises for the pelvic floor. I don't like that very much, because research for low back pain over the last 20, 30 years, shows that we health professionals had a negative impact on our patients with fear-avoiding beliefs and with telling the patients not to do it that way, only to do it that way. You know, there is tons of literature about that. And unfortunately, in the pelvic health area, we do the same things that in low back pain research and communication research has already been proven. So why aren't we taking the results from that and apply it to physiotherapy too? I don't like the good exercises for pelvic floor, the bad. We should get rid of that, because all the research shows that we are so individual, and even that the bad exercises sometimes have more intra-abdominal pressure than the good exercises. So this has to be revised. And in terms of research work, with this approach that I was sharing with my CrossFit patient, I have still one condition in my mind that troubles me a little bit. We do not know with that approach whether during the training time applying impacts, the pelvic floor would have a displacement, like a little bit towards the pelvic organ prolapse. We don't know that. We know that there is one condition where the bladder and the urethra have a displacement, and that there would be, do you say kinking? A kinking of the urethra that could give the impression of being continent, but in reality, the continence is not held by muscles, but it's held only by the change of the topography. And so I still have this in mind, and when we prove this idea, it has also to be controlled by checking whether there is a displacement or a pelvic organ prolapse taking place during those high impact training. Yeah. That would give me even more confidence in applying it. And also it might be that for one patient, there is no problem at all with displacement, and for the other patient it is. And what I love to do, I'm a personality. I recently found out that I am very much like fascia tissue. And this sounds funny, but because I explain it. Fascial tissue is connecting everything. In the same time, it is bordering. It makes a border, a cut between different compartments, areas of the muscles. So it's both. It is border and it is connection. And in a philosophical way, I love to connect the points. And I think it is the time now that we can come from the fascia research and from the musculoskeletal research and put those two ideas together. And I try to explain why I think that way. When I look to the fascia research area, we know that fascia needs elongation in order to stay vivid, lively tissue. We need elongation, and we also need pressure. Pressure and elongation are the triggers that keep the material biologically lively. And in fascia training, the plyometric or the eccentric or the like jumping on your feet would be a fascial training for the musculoskeletal muscles of your leg. Having elongation, impact, you know, we have the phenomenon of the catapult effect that you know very well about the kangaroos in Australia, that it is not the muscle force, that is the elongation of the connective tissue that collects the energy that is given then in the contraction, in the concentric contraction. And so we have to translate that also to the pelvic floor, which hasn't been done so much in my opinion. And what does this, how can we do fascial training on the pelvic floor? And by the way, we have also to change our mind, because we can anatomically, we can view the pelvic floor. Well, these are the muscles that are on the bottom of your pelvis, and some connective tissues are going through it. This is perspective one. And perspective two is, from an anatomical point of view, we have this huge network of fascial connective tissue at the bottom of our pelvis, and some muscle fibers are running through it. Do you realize the difference? So we need to apply the more fascia-based perspective too. So what does this mean? I think both topics can be connected so well, because with our approach coming from the rather musculoskeletal side, we know we need impacts in order to train reactive force and reactive force endurance. So what does it mean? It does mean eccentric load. We think in the muscle way, but when you look to the fascia research, they do the same thing, but they have only their fascia perspective in mind. But basically, it is also jumping and doing plyometric work. So why not bringing those two fields together? The problem is that the fascial tissue is, from a from the methods of research work, it's a hard thing to do. It's a little bit easier to do the muscle research. So we have to find out how we can do this research. And I, for example, if I would still be in research in a team, I would love to find out more about elongation of the muscle, elongation of the fascial tissue, eccentric loading. I would like to find out, is there a longitudinal hypertrophy taking place in the pelvic floor? The longitudinal hypertrophy means that more sarcomeres in the row are produced by the body, by the muscles, in order to be capable of counteract the impact. I would love to prove that. I am really convinced that doesn't matter, You may name it fascial training, you may name it impact training with the musculoskeletal perspective, but I think longitudinal hypertrophy with more sarcomeres in row will take place. I would love to prove that. Find out the methodology for me, please. Can you follow my thoughts?
Yes, indeed. I think with respect to, so what you're saying is the fascial training and the muscle training look the same, and people are focusing on different areas. But ultimately, you have to train the jumping, the running, the impact, the stretch shortening cycle. And it'll be interesting to see if the eccentric loading leads not only to fascial change, but also increased sarcomeres in series. And, you know, this is the basis of why I train so much, you know.
Exactly. And, Anthony, there is the thesis, and I think it has also been proven in some sports science literature, that more sarcomeres in series would mean a higher contraction velocity. When you have more sarcomeres in series, you can contract quicker. That would mean we make the slope of the rate of force development steeper. Wow.
Yeah, right.
Great.
And going back
Can
to
we
what
get
I
it twice
said
as fast though?
Well, that's right. But the rate of force development, I was thinking about, I suggest lower loads, but lower loads doesn't mean slower, right? It's to keep lower loads, to keep the power up, to keep the speed up, to keep the rate of force development up,
I agree with that. Makes sense.
Yeah.
Mm-hmm.
Yeah. So, I people ask me all the time about fascia, and I'm like, fascia adapts just like muscle tissue adapts, and nerves adapt, and bones adapt. And ultimately, we can debate until the cows come home, but you got to get up and you got to do 3D motion. You've got to tolerate high IAP, and you got to do it at a rate so that your body adapts to it, not avoid it. Because like you said earlier, traditionally people have avoided intra-abdominal pressure. Anyway.
There is one method that is already applied for the fascial aspect. You can do studies with ultrasound elastography. And the one group around Linda McLean in Ottawa, Canada, is doing great research about that. And they apply the ultrasound elastography to see what is the tissue change impact of the training. Yeah.
I guess I'm always thinking though too, with the clients that we see who have damaged pubocervical fascia, or like torn or really stretched, and the ones who ultimately do amazingly with mid-urethral slings. And there will be those people who can have really good muscle strength, really quick, well, not 170 millisecond quick, but quick contractions, and who ultimately will leak pretty much, because that sort of level of fascial stretch and damage may not respond. I mean, some will, but some may not respond to training as well. It might just be worth saying, but that's a whole nother conversation. Monika, I'm just cognizant of time, and we were talking before about how you've written a book. And so is this a you're still working as a clinician though, right? So you're doing some clinical work, and this is
exactly. I'm a freelancer.
Tell us about it.
I have 1/3 clinical work, I treat musculoskeletal and pelvic floor health for women. These are my two aspects in my clinical work. And I'm setting up my freelancer status in being an educator and lecturer, not at university, at other places in Switzerland. So I give day courses, I give seminars, I give workshops, and I try to set up that a little bit more now. Yeah. And the book that I have written is only has only been it is only German. It has not yet been translated. It is about body competence. I think I can translate it in that way. Körperkompetenz is the German word. And by the way, if there is out there somebody listening to this podcast and has the capability of knowing somebody who would support to have this book translated into English, I would be very, very happy. So the word body competence is a new word. Have you been aware of that word? This is a new English word? I translate it in a way it's not known in English language, is it?
It's not a term I've heard very often. I mean, body confidence, but not body competence.
Okay. Yeah.
I haven't heard it thrown around much. Have you, Anthony?
Is it to do with your body's, like I often hear it like your body's innate way of healing, your body can cope. But I don't know if it's the same concept.
Yeah, it's a new word, and I also made it up in German. The word isn't either very much used in German. So the word comes from the English word health literacy. Health literacy means to be competent in my own decisions that I do for my health. And I wanted to focus on the body side of that aspect, because all my career, I have been touched by seeing my patients having so different relationships to their bodies. And in this book, I speak about the topic having a relationship with your body. Nobody is speaking about body relationship. We all have our body, and we are the closest one to our body because we live in our body. But how you relate to the body, what relationship you have, has not been yet a topic. And I have been observing and watching that topic for so many years. I have been seeing so many patients coming into my clinic and asking for help. And I consider my work as a physiotherapist to be a facilitator for healing. I think that the body heals itself. I'm only a person who can put a stimulation, an impulse. I can only trigger something so that the body would find back to its own self-regulation. This is my perspective at the moment. And so how could I help a person who has a completely bad relationship, and a person like a female patient hates the body, comes into my clinic, asks for help? How should I promote health and well-being if the person has a very bad, and it's like the body is like the enemy, you know what I mean? Because my perspective and my belief system about my body is influencing my body. And modern research in psychoneuroimmunology is proving that our mind is influencing our body. The minds are influencing health and well-being. And so the subtitle of this book is Coming Home to One's Own Body Through Mindfulness and Consciousness. And so this book is not only a practical book for all the patients I treat and also all the health professionals. It is also a book that has content with theoretical aspects about that, mindset, mindset medicine, mind-body medicine. And I think to have a benefit in our well-being, in our life, in our humanity, we need two things. We need consciousness, that is something that our mind is doing. We can receive new, if we are open-minded, only then we receive new insights, we receive new perspectives, and our mind is digesting that, and our consciousness can develop and grow. This is the mind aspect of coming home into your own body. And the second aspect is mindfulness. And this means that we can approach our body in a very personal way. I can love my body. I can speak positively with my body. When I had my ACL rupture a couple of years ago from a skiing accident, in the healing time, I was speaking to my ligament. I was visualizing, I was working mentally, I was doing 3 hours a day training. I'm happy that I was a physiotherapist, because then you can do much more. But I was speaking positively to my ligament and asking it to heal. And I was visualizing how I was treating it conservatively. I was also visualizing that those two ends could come together and that there could grow a continuity. And so this is not esoteric, this can be proven in the meantime, scientifically, that our mind influences our body. And how much more can we have well-being and pleasure in life and fun with our body if we have a positive and not only a functional relationship, but also a personal relationship. And this is all about what I'm writing on 352 pages.
Well, we just need someone to translate for us, don't we, Anthony?
Yeah, I'll ask Iris who she knows.
I would love to. I have a publisher, and I was speaking with my publisher last week, and I was saying, well, what do you think? Could we have it translated into English? And she said, well, at the moment, no, but if you can find somebody, let's do it. Yeah, if you can find somebody in Australia, in the US, in UK.
I don't know many German English speakers, to be honest.
That would be great, yeah. And I mentioned so many aspects, Anthony, that you also, some of these aspects you mentioned on your course, and that's also was a reason why I was so happy to meet you. I have one chapter about the weight of words. Please, dear health professionals, get awareness about the words you speak. So one whole chapter is about that. Then I have a chapter about diagnosis and prognosis. I mean, my patients, they take the MRI diagnosis for 100%, that's it. And the doctor told me there is bone to bone. I give up. But, if you can change the mindset in a positive way, you have no idea about the potentials. So please take the diagnosis, but digest it, resolve it, and get a broader perspective about it. And don't believe every prognosis. One chapter is about placebo and nocebo. I have been reading nocebo research for, I think, 7-8 years now. And it has such a negative connotation. But in fact, placebo is just showing the greatness and the power of our mind, how much our mind is influencing our health. And there is the so-called open placebo research taking place in 15 years. And we know, even with an ethically spoken out, you can take the real medical drug, you can take the placebo, you can choose, and it works. It works for colon conditions and so on. So one chapter is about positive aging. One chapter is about health promotion, or about unresolved topics. I mean, with now having 35 years of experience in this area, I became more humble than I was in younger years. And also, I think humans need also to work on acceptance too. It is a hard part, the hard part, to accept some conditions. And sometimes from the acceptance, some things can happen, change later on. But first you have to, okay, I accept that. That is part of my life. I'm suffering of chronic pain. How can I deal with it? Not struggling against it. You are always in your sympathetic nervous system state, high arousal. So if you come to acceptance first, your parasympathetic, your vagal nerve will start to become more dominant. This is the place, this is the moment where healing can take place. We know it only in vagus nerve state high, in the parasympathetic nervous system. Our body can heal. So I'm touching, I think, 28 chapters with this book. And yeah, I'm very happy.
I can sense the passion.
Pardon me?
I can sense the passion. It's good.
Yeah.
I think
I'm very happy that I have done it, that I can have it physically here. And also I have more than 300 references in the book, because I want to make people more aware of their knowledge. I want that people prove me. I want that people go back to the references and prove if Monika has written it right, if she's gotten it right, or that people go to the reference if they are more interested than compared to what I shared. So I want people to become more dependent, to think themselves, not to take an recommendation for 100%. I think you know what I mean. So I want to make my patients and all the readers more independent of me and independent of other health professionals and health information, so that they can find their own way. And this is what I meant with competence.
No, that's awesome. And I'm thinking there's a book, Monika, that I read a few years ago, Mind Over Medicine. I don't know if you've read that one.
Tell me again the title?
It's called Mind Over Medicine.
Yeah, I know it.
By Dr. Lissa Rankin. And it's a very similar topic in terms, but she goes through all the research and things. But it sounds like what you've done is gone into a real sort of more practical approach, like how can you use this knowledge, which, like you said, we've got a lot of research on the fact of mind over body experience and how it can influence pain and healing. And I was fascinated by some of the research that was showing, you know, like women who have, I don't know, breast cancer, and how their survival rates are much higher if they have, I don't know, whether it was 5 or more really close friends or something like that. So it's just fascinating topic. But it sounds like what you've done is given people some more strategies on how you can actually take that information and use it to empower yourself to take control over your health and well-being, so that you can live a more fulfilling, joyful life, potentially, hopefully.
Exactly. That would make me so happy. And you know, it is really about empowering people to love their body more through reading this book. And this would be such a tremendous game changer in their life. And I view myself as practicing, and I write it in the foreword. I'm practicing on the way. I try to guide you through a path where you can find into more self-love for your own body. But I'm still practicing. I'm writing some chapters to me also, you know. I'm not at that level. I've done, and I'm learning. And I'm really like building a bridge between research and very practical approach. And I think I'm also building a bridge between science and spirituality. I have a lot of psychological, philosophical, and also spiritual aspects in this book in a non-dogmatic way. I do not like dogmas anymore. And I think it could be that the scientific world would say, oh, Monika, she is too spiritual. And the spiritual world would say, oh no, Monika is too scientific. I don't mind. I think one of my essence, I think I use the word essence. So also the feeling of why I'm being here in this world, in this incarnation, is perhaps to be there, building the bridge between those two fields. I don't know. I have the feeling about it. We will see.
I love it, Monika. I honestly feel that is part of my calling as well, which is to bridge the professional world and the practical everyday layperson world. And a lot of what I teach, like what you said about writing chapters for yourself, a lot of what I teach, all of what I teach really is to remind me what I have to practice doing every day, right? It's not because I'm good at it, it's because I need to practice doing it. It's been a fantastic time talking and listening and learning from you and sharing with you. We love your approach. I've got the unenviable task of summarizing what we've talked about. So we started off with your early days, including the psychosomatic clinic, which heavily influenced, you said, the holistic approach, and where you are now, really, through your clinical practice into the research and the interesting findings from the jumping and the running for you, and the jumping with, Helen, and, all the unresolved questions that we have from it, and how, you're more broad-minded, I suppose, now, less certain the more you've gone along, and this is the way to go, and then finally finishing with the passion that you have for empowering the German-speaking population to begin with, in taking control rather than giving over their control to somebody who says, this is it, and then they're stuck saying, well, this is it, the doctor said this is it, like there's no more hope. I can tell you lots of stories, I won't, I'm very contrarian, as you might know. So this speaks a lot. I know that Marika and I both love challenging things. So thank you very much for this time. What's the best way to get in contact with you? Because you literally wrote, I am abstinent from all social media. So it's such a great way of putting it. How can people find you, Monika?
You can find me on my website, which is unfortunately only in German. This is www.vita, like the Latin word for life. Minus impulse.ch. And there you can also find my email address. Fantastic.
We'll make sure that that's in the show notes. It's been a fantastic chat. I really hope the book does well for you, and it would be great to have it in English. And if there's any German speakers out there, please reach out to us or Monika, and we look forward to hearing more about how it's going. And hopefully I can come back to Switzerland and do more courses, and would love to catch up with you again.
Me too. I would love to.
And come to Perth
and visit
Marika.
I just want to go to Switzerland. I just want to go to Switzerland.
It's beautiful. It's so beautiful. I loved it there.
I haven't been there in like 20 years. Thank you so much, Monika. Really appreciate your time.
Sure. Thank you for having me. It was a very nice conversation with you. Thank you.
Thank you. Well, that's it for this episode. Be sure to hit like if you enjoyed the episode, and leave any comments or questions below. We'd really like to hear from you.
If you haven't already hit subscribe, please do so now so that you can be kept notified when we release our next episode.
Otherwise, thank you for listening, and we look forward to having you back with us for another episode of the Women's Health Podcast.